Hello, and welcome to the Surgical Assistant Podcast, a podcast crafted by surgical assistants for surgical assistants, where professionalism meets passion. Hey, everybody, welcome back to the Surgical Assistant Podcast. I'm John.
I'm Kelly.
Hey, Kelly, how are you?
I'm good. How have you been?
I've been great, thank you. And as the topic of tonight's podcast is, we are doing the conference recap from the Joint NSAA ASA. Was it the sixth annual, I believe, the sixth annual conference?
Yeah,
That
I
was in
think so.
Grapevine, Texas. We're going to talk about that. And for all of you that weren't able to make it, also for those that can make it, we highly recommend that you do attend a conference because it's so much more than just CEUs. So I'll let Kelly kick it off. We'll talk about, I guess we can start with the pre-conference workshops. There were two pre-conference workshops, a morning workshop, which was on the Venapax endo-vein harvesting system, and the afternoon pre-conference workshop, which was on the Ross procedure. So
Yeah, so
kick it off.
we both flew in on Thursday. John and I had not seen each other in at least 3 years, I think.
Long
And
time.
so it was good to see each other at the conference. And we had a bit of a hiccup with weather. The weather was bad in Dallas, so we had delays, and that was a whole thing. Like, lots of people were delayed getting in, but once we got there, everything was fine. And it's great that they make these conferences where the conference is in the hotel where they have the group rate, and it's just very convenient because you land at the hotel and you're there. So if anybody's wondering about that, that's a cool thing, as most conferences are. They're in a hotel conference room setting, and you have a group rate to stay there. So you don't really have to go anywhere if you don't want to. So we arrived on Thursday at different times of the day. And these pre-conference workshops are typically given on the Friday before the regular conference starts on Saturday. So you have the opportunity when these conferences come to look and see what the workshops are being offered. And it is an extra fee, but it's also extra CEUs, and they count obviously as live or advanced CEUs. And you just get to learn again. Even like John just said, it's more than even just about the CEUs. It's knowledge that you can't, once you have knowledge about something, you can't take it away. So I only signed up for the endovein harvesting with Venapax workshop. John signed up for both of them, but I was able to actually sit in and proctor a little bit of his conference on the Ross procedure. So we'll talk a little bit more about that when that comes. But yeah, so I thoroughly enjoyed the EVH workshop, John, and learning about the Venapax system. I was only previously familiar with Terumo and McKay system, and I do not take veins, so I don't do this on the normal, but I've taken a couple of workshops kind of learning about both of the other main systems that are utilized. And it was really cool learning about the Venapax. The advantage, my takeaway from it was the advantage is the user friendliness of it. That it's significantly easier to learn how to take vein with the Venapax, and you really decrease the intimal and ventitial damage to the vein as you're taking it with this system and the way that it works. So the way that this goes is we had a little bit of a lecture. Michael Morrison is always our expert and go-to in the cardiothoracic realm, and he gave us a good talk on anatomy of the heart and the function of the heart, and then how we're also taking vein, the anatomy of the leg and whatnot, and what our landmarks are for taking the vein. So we had a good kind of little lecture part, and then we kicked off, and they give you plenty of time to kick off into the um, didactic part of the workshop. So while we weren't practicing on cadavers, I felt like the material that we were practicing on was very human-like. Did you?
Oh, definitely. Yeah, it was, although I've never done it before, so I have nothing to compare it to, but it was definitely, it was an intuitive system to learn, number one, but it was also, yeah, it did feel like something close to human tissue.
Mhm. Uh-huh. We were at a disadvantage because they were not able to get CO2 so we didn't have the gas blowing up the tunnel for us. So still we were able to get an idea of how the system works, which I think is the
Mhm.
whole point, how the system works, how you tunnel up on and kind of dissect out the saphenous vein, and then the most important part is taking those branches and really keeping the damage really not to a minimum, but not damaging the vein at all. Because we are when you're doing that, you're harvesting the patient's new coronary artery which I've heard before, but it's really a serious thing when you're taking vein. So, um, it was a great workshop. I It was high quality, I felt like. It really We were able to spend a lot of time with the, rep. They had 2 reps set
Mhm.
up teaching us, and we kinda just gathered in groups, and while we were waiting to our turn to go up and kinda work with the system, we were able to network a little bit and talk to one another, and it was cool. I enjoyed it.
I thoroughly enjoyed it. I thought it was one of the best workshops I'd been to in a long time. Now, they usually try to put on, an vein harvesting workshop quite often, but this does not in any way qualify you to take vein. You're not gonna get a certificate and go back to your hospital to take vein because it's so much more involved than that, but it's an introductory hands-on, class in vein harvesting where you learn the parameters, you learn about the different systems, you learn all about dissecting out the saphenous vein, and then you get to do it hands-on with the little simulator that they have. And I thought Michael Morrison, he always gives a great lecture on anything cardiothoracic because that's his wheelhouse. He's been doing it for a long time. I think he's really excellent at it. I think he's a great teacher. But
Mhm.
what really struck me about it was how much he hated this system initially because he hadn't used it and thought he was good with the Taromo and the McKay, and he didn't want to learn another system. And then when he actually gave it a chance, he realized how number one, intuitive it is, number two, how easy it is, and number three, how safe it is to harvest the vein. You have bipolar cautery instead of monopolar cautery.
Right.
And from everybody I've talked to that have harvested vein with this system, say that they are shocked at how pink and alive the actual vessel looks when you take it out as opposed to like something pale and stringy looking that you get from harvesting from one of the other systems. So,
Yeah, I'm
um,
glad you brought that up. He had to keep telling us,
mhm,
I am not being paid by Venapax. They are not paying me to say this." And so he was able to talk to us
mhm,
from with that firsthand experience, John, from one practitioner to
yes.
another, and that meant a lot hearing that from him. As a matter of fact, you don't ever know what's gonna come out of when you go to a conference, and I was able to bring this information back to my director in the operating room where I work. She happens to be the director over CVOR, and currently at our hospital, they're hiring in a company to come in and take vein instead of teaching the FAs that we have in-house to take it and do it. And so I was able to tell her about taking this class, tell her about the system and how great it was and how easy it was to learn. I mean, and the statistics
Mhm,
of the comparison for how long it takes for, um, a practitioner to be taking vein on their own using one of the other systems versus the VenaPack system, it was significant, and the rep told us, and you can correct me if I'm wrong, but I don't think I am, that he said in after like 5 or 6 patients of him proctoring you, you're ready to do it on your own, and that's just
mhm,
unheard of. Now, I can't speak from experience, but he
mhm,
said that, Michael backed up what he was saying, and very interesting. So I've actually got my director wanting the information of this rep. She wants to talk to him about them coming to our hospital and teaching the FAs to take vein hopefully with this system. I don't know how that's gonna work out, but my point of saying that is that you don't ever know what you're going to be able to take away from these workshops and how you're gonna be able to go back to your facility and maybe improve a process, introduce them to a new device that it's that's great and needed and safer for the patients. So that's a really cool aspect of it as well.
yeah, I totally agree, and that's what I remember too. I think I remember him saying, like, within 3 to 5 cases, you'll have the hang of it, and you'll be well on your own after that because it's just intuitive and easy to use, and to me, just like with any conference, their speakers have to give disclaimers if they're a paid consultant for a company, and he
Mhm,
is not a paid consultant for Venapax, and that to me just is worth so much. Somebody who is honest about that and, is a convert to something, and they wanna promote it because strictly for the fact that it's a better mousetrap.
mhm,
There's nothing in
mhm,
there for them. They're not getting paid to say that. They're not getting a trip comped or this. It's just like what all of us, when we choose something for our patients, we choose it because it's the right thing at the right time for the right patient,
mhm.
not because the rep gave me a pen or bought us lunch. I mean, I don't know why people think we're easily swayed like that. It's just I
Right.
find it insulting, I really do. "Oh, you can't give me a pen because I might use your product over something that's better. Give me a break." But anyways, that's what I love about those conferences. The pre-conference
Mhm.
workshops are awesome. I'm waiting for another one on cast and splinting. I'd like to
Mhm.
see one on ultrasound, just specifically on ultrasound, teaching us how to do a fast, teaching us
Yeah, they're
about the
so
different landmarks, TAPS blocks, stuff like that. So the
mhm.
room is open and they're open to suggestions. So I always make my suggestions every year.
Right. Right, and before we move on to the Ross procedure workshop, I
Mhm.
do wanna mention that Venapax was previously owned by Safina, Saphena, who I had never heard of, but Zimmer just bought them. So, Venapax is now a Zimmer product. They just bought the company. So, if anybody wants to look that up, I just thought I would throw that information out there if they wanna look up that system. You can just
Oh,
Google Venapax into vein harvesting and it'll come up. But let's talk about the Ross procedure and what that is. I was so glad that I was able to sit in there and listen to it because I didn't know a lot about it.
oh, exactly. And it's an aortic valve replacement surgery that uses the patient's own pulmonic valve where they transpose it and then they take a donor graft and recreate the pulmonic valve that you just harvested. So I don't do cardiothoracic. I didn't know about it. And I was like, that sounds like a lot of work when you could just put an artificial valve in there. But as we all know, artificial valves aren't without their own problems in and of themselves. Patients have to be on lifetime anticoagulation if they choose a mechanical valve, or the the issues are endless. But one thing that stood out for me is the amount of interventions after these people have had a procedure, or almost none. Once this procedure is done, they're usually good to go and they can live a normal life expectancy. Whereas with artificial valves, they run into their own problems. They wear out, they have to be replaced. You can get other issues with those. So I was blown away to hear that. And I was like, I could see why it's worth all the work. And once you get it down to a science, you can really have the case done. I think Michael said they were doing them within 2 hours, 2.5 hours, like an
Yeah,
hour and 45 minutes of pump time, I think.
yeah,
But
yeah. It's amazing, and there's not I don't remember the number, but it's not a large number of surgeons that are doing these in the United States. So
no, not at
I mean,
all.
it's a fairly new and up and coming technique.
Well, it's
Very
been around
interesting.
since the '60s. Yeah, in the mid to
Yeah.
late '60s is when this doctor perfected it, but yeah, it's gaining in popularity now
Mhm.
because for certain populations of patients, it's the way to go, young patients that,
Right, and they
you
talk
know.
yeah, and they I like how they talked about the candidates, the patients that were
Mhm,
candidates, or they talked about absolute contraindications, and I always, enjoy
mhm,
hearing those facts as well when it comes to that. But then I stepped out,
mhm.
of the conference after the talk part, and you stayed on to do they actually had a pig heart. Was it a pig heart there for you
Oh,
to
yeah, it
work
was a
on?
pig heart. That was,
Mhm.
for me, the best part about it was there was just enough people to where every group had a heart, and there was a group was anywhere from 2 to 3 people. There was even one guy that was by himself because I guess his partner left. But yes, you got to do the procedure itself. They talked you through it. They would explain what the next step was and then how to do it. And then they showed a video of an actual procedure being done. Now, granted, there's some variances between obviously a pig heart and a human heart, but it's
Mhm.
close enough. And it's set up in an apparatus, so it stands up. They have the suture there, the Castro Viejo needle holders, all the stuff that you needed. And basically, there were 3 people in my group, another gentleman, and then a lady, and she just wanted to video it and ask questions, and she did a few suturing. But yeah, we each got to do a part of the procedure. Well, it was opening the aorta and then harvesting the old leaflets out, and then, or removing the old leaflets rather, then harvesting your donor site and then sewing it in. And yeah, it was fantastic. We all got
That's
to do it
cool.
and
Yeah.
it was wonderful. And they were right there. I mean, the instructor to student ratio was good. I mean, they had 2 reps there also who were a great resource. They could talk you through the procedure because they knew the procedure intimately. So, but Michael and was it Todd? I'm sorry, I'm blanking on his name.
I think it
I don't
was
see it in my notes.
that sounds familiar, but I can't
Yeah.
remember.
Well, there were 2 essays there, both from University Medical Center in Cleveland, where Michael works, because they do this procedure there, and they both do a Michael and Todd are both surgical assistants, and they do this. They assist with these procedures. They were right there to talk you through it, show you what to do, give you any caveats, and then we got to do it. And it was kind of like we all do one step, wait till everybody catches up, do the next step. But then some groups will work ahead because the reps were standing right there and giving you advice and dropping little anecdotes. And I thought it was wonderful. It really was. It was great. You get to meet people, you get to talk, find out where other people are from, what they
Mhm.
do, and there were quite a few from Texas because this was in Texas, so there were 2 people in my group that lived in Texas, which I thought was good.
And that
Yep.
experience is almost priceless because you're not where else are you gonna be able to do that? It gives you a grasp
Yep.
of how the procedure works.
Mhm.
Obviously, we know it's a pig heart. We know it's not very realistic, but it's as realistic as you can get without operating on a
Joint
person. So
cadaver.
when you're at they're actually letting you do the procedure, so you're learning about the procedure then with that hands-on and doing it, but you're
Exactly.
also kind of gaining the surgeon's perspective and
Mhm.
knowing what the surgeon is doing and how difficult it is and being able to assist him is what makes us good assistants. So really,
Exactly.
I always try to look at it from that, like, if I put myself in the place of the surgeon, what is he trying to accomplish in any surgery, really? What is he trying to accomplish? How technical is it? How difficult is it? And how so then let me put myself in his place, and then I can assist him that my assisting then goes up, like, about 4 notches because
Mhm.
now I'm really trying to get in there and really help him, and when I understand what he's doing, why he's doing it, how he's doing it, it just makes sense that we're gonna be better assistants. So,
Oh, bingo. That's what I
you
try to get across to people, that you cannot this is invaluable. Yes, it's a pig heart, but that is the highest fidelity that we can get, unfortunately, at a conference because now
Mhm,
the only other thing we could do is use a cadaver heart, which we can't
mhm,
do, number 1, at a hotel. They won't let you do that at a hotel. They won't let you use human organs at a hotel.
right,
We could get whole cadavers in, and we could perfuse them, and we can actually do the procedure, but that would increase the cost probably $3,000 per person,
for sure.
which is unattainable for all of us,
And let's
honestly.
mention now that you said that, let's were these $125? I think $125 for each course, so that's all it
Yes.
was. It was
Yep.
$125, y'all, and it was 4 full hours. So and you got of
Yep.
each I'm talking about it for each one. So you had an closer to an 8-hour day.
Mhm. I
But yeah,
did.
you're getting the lecture, you're getting the hands-on. It's really invaluable. It's just how much do you wanna
Yep.
invest in yourself? How much do you want to invest
Yes.
in your practice as a first assistant? John and I, you can tell, are both passionate about it. We advocate to do that very thing, to
Mhm.
invest in yourself and invest in your profession as a surgical assistant. So,
Yep.
it was cool. I'm glad that rounded up Friday for us. I mean, that was great.
Yep. Exactly. Because not to beat a dead horse, but to echo exactly what you said, I mean, that to me is the value of this because when you actually do it yourself, you realize how technically challenging it is, and you instantly know how to help. And
Mhm.
you can't I mean, it would take you cases of assisting on that to learn that stuff. Now, coming right out of the gate, you have a better idea than you would be on your first case had only watching videos of it. But now that you've actually done it, technically where the hardest parts are, how to help, how to provide
Mhm.
exposure, how to follow their suture correctly, all of that stuff, what you're going to need for the next part. So, and that's just exactly right. If you're consider yourself a professional like I do, like Kelly does, like a lot of us do, then you need to invest in yourself. And
Mhm.
yes, it's an expense, $125 on top of a $275 conference and the hotel
Mhm.
and your airfare. It's a significant cost.
Mhm.
But what you get back, it makes you such a better assistant, even if you don't do cardiothoracic. It's
If you don't, yeah.
still improving your skills and your knowledge, and you feel better about yourself as a professional, that you are growing as a professional and learning new skills. That's why
Mhm.
for me, I mean, conferences are invaluable. I look forward to them, and I try to get the most I can out of them. But I thought that was
Yeah,
a great
yeah,
one.
because
And
you
you're
can't
right.
have tunnel vision either. Things that you learn and things that we learn and nuggets that we get in these, like, even specialty specific, um, talks and
Mhm.
classes and workshops, you don't ever know when you're gonna be able to take something away and use it completely somewhere else in a completely different, area of surgery, and I've had that happen
Oh
before.
yeah.
Like, so
Hmm.
you don't so never ever say, "Well, I don't do CVOR. I'm never gonna do CVOR." John and I, neither one I've worked in CVOR before, but neither one of us do currently, and we were still able to thoroughly enjoy and take things away from these work pre-conference workshops that very valuable and will go
Hmm.
with us into our regular work day. So,
Exactly.
it's really
And the
cool.
CEUs are always a bonus. So I got
Mhm.
CE 8. I've got 8 CEUs for that day. just for the
Mhm.
pre-conference workshop, and then the conference itself on top of that.
Yep.
So, I know because I
Yep.
just renewed my CSFA this year. I just did all the paperwork and
Put you in
submitted
good
it last night.
good
I think
shape. I
the
know.
NBSTA website was down for a couple of days because I couldn't access it. I tried
Yeah.
several different places. But anyways, so yeah, I'm sold on the role of conferences in your professional life. I mean, they're a must.
Yep.
Anybody who considers themselves a professional should go to their professions conferences. You see surgeons going all the time, and
Yep.
it's required of you. It's definitely, if you consider yourself a professional, it's required of you.
Yep. Okay, so then Saturday morning, we kicked off the part of the conference, the conference itself, and how they start the day off is usually with the joint state of associations. So both
Hey, Kelly,
residents
before
are
you get into the
yeah.
joint association, did you want to
Oh,
talk a
yeah?
little bit about the keynote speaker on Friday night? Or do you
Oh,
want to save that
yeah.
for later?
Yeah, that's right. So we do have the keynote speaker that did kick off Friday night. So yeah, it was I do you wanna talk about him? I've got some notes down. I think he ended up talking I don't was he the one that talked that kinda had to change the subject matter that he was talking about at the last minute, or was that somebody else? Somebody had to kinda change the talk.
No, he was,
Kirk
he builds
Offel,
data Kirk Offel, yep.
Offel, Offel,
Yep, he builds data
Offel.
centers for a living, but he was
Mhm.
a veteran. He didn't say what he did on a submarine, but he was a submariner. He was on, I looked it up, it was the USS Memphis, which was a Los Angeles
Right.
class fast attack sub. I meant to catch him
Mhm.
afterwards and ask what he did, but I didn't. But he talked about his personal journey and how important it was to him to encounter people along the way because he was diagnosed with an osteosarcoma.
Mm,
I think he was in his 20s when it happened, and it was only because of the persistence of another combat medic who turned out to be an orthopedic surgeon he didn't know in the area, and saved his life by recognizing the signs and symptoms early and then getting it diagnosed and getting him treated. And he talked about his journey through the whole healing profession, but how it made him determine what was important and focus on that. And he said if he died today, he wouldn't be doing anything different. He'd be living his life, but he's living it
mhm.
to the max, doing what he loves and helping people.
One of the takeaways I wrote down that he said that I love this quote that he said, "Be in service of your purpose." Like, figure out what your
Yeah,
purpose is and be in
great.
service of it. Like, do it with your
Mhm,
whole heart.
mhm.
And this is one of those professions, John, that you don't need to be doing it if you're not in it with your whole heart. We've got an
That's true.
episode coming up that we're going to talk about the ethics, the ethical, if you will, of the operating room and what it all entails working in our profession when it comes to ethics and morals, really. But if you don't believe in what you're doing with your whole heart and you're not really passionate about it, find something else to do. I mean, this really isn't the profession to be in it for the money, which we all know. I mean, we're not all I don't know about you, but I'm not getting rich off this job at all. I mean, I'm thankful for the fact that I can make a living doing something that I love. I'm very grateful for that, but be in service of your purpose. And I underlined that and highlighted it in my notebook. That just really hit home with me, him saying that. And after he talked about his life experience and all that he went through. He was able to it was a pleomorphic sarcoma that he was diagnosed with in his right knee, so it was his leg, and he became a triathlete and an ultra marathon runner during and after his recovery, which me j even I consider myself a halfway runner. I try to
Mhm,
get out and move and log miles the best I can, but that just floored me that he was able to do that through that diagnosis of a lower extremity
mhm.
nonetheless. Just a lot of grit and determination and a good support system and knowing what his purpose was in life. So, that was a very good motivational talk, I felt like, yeah, for sure.
Yep, I
Also, I don't know if you wrote it down, but the other takeaway from him because he is in data center technology, and so when you start talking about high tech AI and technology, it's gonna go right over
mm,
this curly head of mine. But the takeaway that I got from that, John, is he told us, he said, "You're in a profession that your skill is valuable and there's not a robot or a computer is going to replace you. Like you're in a good place, you're in a good profession and you're valuable. You have a skill that is it's not expendable. It's not an expendable skill. So we should all be take that to heart and be thankful that we're able to do what we're doing."
I agree. Yeah, I don't think as much as people are touting AI, I don't think it's gonna be what people think it's gonna be. Just like machine learning, just like Y2K, I mean, people always
Mhm.
overhype these things. I definitely think there's a place for it, but I don't think it's ever gonna get to a place to where they'll lay you down inside of a machine, and the machine will diagnose your issue, do like an
Yeah.
MRI or a CAT scan, and then come up with a surgery, and then be able to remotely do the surgery without any input from another human being. It's just not gonna happen
No,
because it's so subjective, and it requires a human's ability to think on the fly and in 3 dimensions to be able to accomplish it. But yeah, I definitely think it's definitely gonna enhance our profession. But I remember when I was in tech school, they said, "Oh, we're coming out with a robot that's gonna be able to scrub and hand the doctor instruments," and that never came about. There's nothing that can do that
that's interesting, yeah,
because
that's
it's
just
more than just passing instruments, you know?
Mhm.
You can't just reduce a surgical tech's job down to passing instruments. It's so much more than that. So,
Right, right.
yeah,
So,
it was a great
yeah,
speech.
pretty interesting, yeah. That was good. Very high quality speakers that they really endeavor to get for us and people that are gonna invest in us and pour into us,
Mhm,
and I can't say enough about how much I appreciate the work of our associations and our board members and
mhm.
what they put into and getting people to come to these conferences and speak to us. So,
Yes, the one from the Las Vegas conference a few years ago still sticks in my mind because it was a fight doctor for professional boxing and the MMA fights, and he talked all about what's involved in concussions and what's involved in his care of these patients and how they're evaluated after they're knocked out and all this anecdotal stories. It's still one of the best keynote speakers they've had yet,
nice.
and all the keynote speakers are good. There was one they had one time, but it was a pinch hit. Their speaker canceled at the last minute, and it was a pinch hit, and it was okay, but it wasn't stellar like this guy was and like that gentleman was in Vegas. I mean,
Yeah.
it was a way just a great kickoff to a great conference.
Mhm. Yeah, it was, I agree. I agree. So, yeah, moving on to then the joint state, we kinda move into, like, a business they have a little business session before we start our Saturday sessions with the different speakers, and we talked about the Association of Surgical Assisting and the National Surgical Assisting Association, the state of those associations, and we were addressed by the head of the NSAA, and they like to introduce the board members of each organization. They announce any that are board members that are departing and their new member replacements. For instance, the NSAA president is stepping down, and Helga Olson was nominated or voted in as their new president. And we talked about the ASA town hall platform being established, which that town hall did take place yesterday as we're recording this on Sunday. It did happen on May 3rd, and they did a really good job of advertising that on our media pages. But Fred Fisher got up and talked to us about how the encouraging open dialogue and talked about also the virtual September conference with sessions and workshops and how important that is. NSAA got up also and they talked about their accomplishments as a organization over the past year, how they had accomplished some financial solvency, they reduced spending and were able to reduce the dues for the NSAA, so that's fantastic. They are having a stronger social media interaction. They've had an increase in young membership, which is fantastic, and joint efforts in state legislation. So we're both organizations, we're always aiming for the state legislation and changes in that. And then the big announcement. I mean, the big announcement
Mhm,
of the conference was so exciting, and we're gonna have to take a few minutes talking about this, is
mhm.
that they announced, and apparently this has been in the work for some times, but they announced that the ASA and NSAA are looking to merge into one organization, and the name will be the American Academy of Surgical Assisting or Assistants, or
Assistance.
assistants. The American Academy of Surgical Assistants. So that was big news, and there was a little bit of I've seen a little bit of confusion, and even I had the question in my mind, and they then as they talked about it and spoke about what this meant, they answered my question. So we are still definitely, to clarify to any of our listeners, going to have 2 certifications, John. There's still gonna be the
Mhm.
CSA and the CSFA, two different certifications, one organization. Okay. So we're two separate organizations now. We're going to merge. So they didn't really have a specific timeline of when this would come to fruition and be complete, but it's very exciting. I know they're working. One of the main things they're working on is trying to streamline how we evaluate our CEUs and how our CEUs are rewarded. So that's a big issue in having one organization, but still the two certifications. So still CSA, still CSFA are the two major certifications. But I think that's one of the major issues that they're gonna have to work out and iron out before it becomes official. So they didn't really have even a they didn't give us even a tentative date or time frame when this would be complete, but knowing that it's in the works, we know that there's strength in numbers and being unified is a good thing. So I'm excited about it. I was really happy.
Yeah, I'm excited as well. Initially, what they have to do when they form it is they have to make an announcement, like a letter of intention, and that's basically what they did. They announced to everybody, but nothing's changed as yet, and it's going to be a long process and a very careful and thought through process. Nothing's going to happen overnight. Nothing's going to happen immediately. And exactly what Kelly said, the certifications are the NSAA and the ASA are membership organizations. Their function is to serve their members. Now, the NCCSA is the credentialing body that issues the CSA exam, administers it, issues the certification after you pass it. And then we all know for CSFA, it's the NBSTSA that issues that credential. So those credentials aren't going anywhere because those credentialing bodies are going to stay the same. But as far as a membership organization, I like the name better. I just think it sounds more aristocratic, more regal. I think it's long overdue. I think there's a lot of history with the old, how do I say politically correctly say it? There's been issues in the past between the different organizations and the AST, NBSTSA. And I thought one of the greatest things they started doing when I first became a first assistant was the joint conference. I mean, this is the sixth
Right.
joint conference, right? Yeah. And I remember the first joint conference. So combining the leadership, combining the two groups together is a fantastic step forward. Because let's
Yeah.
face it, in this profession, we have three different credentialing bodies, three different credentials, three different membership organizations. I think it's time we get our act together and we streamline it and we work together as a group. Whether you're a CSA, CSFA, we all do the same job and we're all moving in the same direction. And we need to promote each other. Now, one thing I did find interesting in what they mentioned is the SA-C or the ABSA won't they can be affiliate members, but they won't be full members of the association because of the issues with that certification. So we don't discriminate against any certification on this podcast. This is for everybody, and the pool is big enough, but they don't have an accredited exam right now. It's not a peer-reviewed accredited exam, and it's not a KHEP accredited program, so you cannot sit for the exam after you graduate one of the few schools that teach that curriculum. So whether it's ACE-SA or Royal Academy of Surgical Assisting, and I think there might be another one that I can't remember off the top of my head, you can't go through their programs and then sit for the CSFA exam. So you sit for their own exam, which is the SA-C. So, but moving forward, I think it's a great way to just focus our efforts and combine our numbers because there's strength
Yeah.
in numbers. So I think it was
Mhm.
a great announcement. I think there's fantastic things ahead. It's all new people, new blood are coming onto the board, and that means new ideas. And I think it's great. I think it's great. It was a
Yeah.
fantastic announcement. And
That's
total transparency, I was late. I overslept. I wouldn't have made it if it wasn't for Kelly calling me and say, "Hey, where are you?" I got up early and then I laid down for a minute and fell asleep. So that's my fault. But
Yeah. But yeah, that was yeah, very exciting. So then, we just talk about kind of business stuff, and they talked about a few details around that and kind of clarified some things for us. And then we were able to move into the first speaker of the day, who is Dr. Mark Poole, a CT surgeon. I didn't write down where he's from. I sure did not. Was he? I don't know. Was he local? I don't know. It doesn't matter for the purposes of this podcast. It doesn't matter. It
I
was
believe he was
interesting
local.
because I was excited because he was gonna talk about working with the grumpy surgeon. He
Mhm,
was gonna talk about how to deal with a grumpy surgeon, and that talk kind of he said things kind of just didn't come together for that. So, he gave us a good talk about technologies in cardiothoracic surgery and heart surgery and whatnot. He was a great speaker. I really enjoyed him. Great. If his personality is anything like in the operating room is anything like it was at the conference, he'd be just a pleasure to work with.
mhm.
He talked to us about things like ECMO and the Impella, ventricular assist devices, TAVR, MitraClip, robotics and the role they play in CT surgery, CAB, which is totally endoscopic cabbage, which I've never seen. I guess that's completely robotic. What it said.
Mhm.
It's a completely robotic endoscopic bypass, heart bypass. And he talked about how he's hoping for an increase in simulation training when it comes to robotic surgery and specifically in cardiothoracic surgery. So he had good jokes too. He had good clean jokes, which I enjoyed. Um, what was your takeaway from him, John? I mean, I know he challenged John. He talked about uh at the beginning, he said, "What's the first surgery? What's the first surgery that was ever performed?" And so I threw out amputation before I remembered that it was actually trephination. I should remember that from our surgical history
Mhm.
episode. And so some people were saying a few things, and then he got us and said it was a rib resection and to read Genesis chapter
That's right.
2:21.
I thought that
So,
was
it was
good.
pretty funny. Yeah, he was a good very, very good speaker, and he was from local. I think he was
Yep.
local from there, yeah.
I believe he was local area, yep.
And so, you wanna talk about the next speaker we had? Dr. She.
Dr. Shi, yeah, I always struggle to pronounce his name, but yeah, Dr. Shi's presentation was on coronal and sagittal deformities, the management of coronal and sagittal deformities. While he talked a lot about kids, he also talked about older people too and scoliosis, and he gave the parameters and the diagnostic criteria for scoliosis. He talked about things that contributed to it. Idiopathic scoliosis is rarely seen in kids under the age of 10, which I was unaware of. And
Mm,
he talked about the let's see. Yeah, I'm not gonna go into all my notes. It was really good. He talked a lot
yeah,
about the diagnosis criteria, the radiologic criteria, and then the progression of the disease and why it
right.
was so important to the curve progression and how bad it can get. And you think it happens slowly over time. It may be after 50 degrees or more, it can progress at 1% per year, which can be pretty significant if you're
Hmm,
young. You can be totally debilitated by the time you're in your 40s or 50s. So he talked about that, the types of surgeries, the goals, improving for kids. He talked a lot about kids. It's imperative for kids because it improves their self-image, it helps their balance correction, it prevents progression. It's you're not only straightening the spine, you're also controlling the rotation of the spine as well. That's why he talked about coronal and sagittal deformities. He talked about how often kids are screened, the difference in sexes. He talked about coronal plane deformities and then sagittal plane deformities, the different types of obturation, the different type of operations to correct each type of deformity, whether it's in the lumbar spine or thoracic spine or cervical spine, pedicle subtraction osteotomy, vertebral column resection. And he talked about the spinal pelvic parameters in making the diagnosis and then he went into adults. Yeah, I thought it was fantastic. It was a remote lecture because he
mhm,
had to Uber for his kids, but I thought he gave a great lecture. He answered questions, people are able to answer questions, so normally I like it better, obviously, if they're in person, but I thought this worked just fine, and I got a lot out of it. I like spine, I like doing spine. I don't do a lot of corrections on kids, so this information was really important to me to make sure I took good notes, and I also audio record the lectures as well because I can't write that fast. And darn it, I forgot to mention to them again, but I have to really work on them to get a separate website put up where they can have the speakers load their content onto there so we can go back and refer to it and have it
yeah,
as a resource. So if I want to complete my notes, I can go and look at the things I missed because they can't write it all down. I don't write that fast. So
right.
but I thought it was a great lecture. What
Yeah.
did you enjoy it?
I agree with you. I mean, he was high quality, and after just a few minutes of him talking, I didn't even think about the fact that we were looking at him up on a screen and that he was remote. I didn't even
Yeah,
think about it. It was so interesting.
yeah,
Again, I don't do a lot of spine surgery, but it was, again, just taking away those nuggets that we can learn, and it was very interesting. High
mm,
quality, and he had a great demeanor. Just seemed like a very nice guy. I guess I wouldn't say any of that if I didn't really feel that way. I just wouldn't say anything about his
right,
personality, but he just seemed like a great guy. And
mm,
just our point is it's easier to listen to somebody. It's just easier to listen to somebody that has a good personality and speaks well and just talks about what they do and the ins and outs of all these different conditions, and very, very quality, and I enjoyed it immensely, and I was able to take some good notes too, John.
yep,
Moving on from Dr. Shi, Dr.
mhm,
Patrick Shi was his name. SHIH was his last name, if anybody
yes,
wants to look that up. Um, gosh, we heard from the PICO, the negative pressure wound dressing, and this was an invaluable, I think the entire room really enjoyed this. Very
mhm,
practical information for PICO, whether you used it a lot, a little, or never heard of it. It was a chock full of good information.
mhm,
These notes are gonna come in handy that I took on this. Don't use it a whole lot where I am currently. I have used it a fair amount in the past in my practice and different facilities I've been in. But again, just learning just really good nuggets of information on the PICO negative wound, pressure wound dressing. We talked about the blistering and avoid overstretching. In
mhm,
any adhesive product, really, we want to avoid overstretching and how it can blister the skin. The PICO is indicated for both open and closed surgical wounds.
mhm,
One of the main clarifications that I appreciated from this talk was that it's a it's a negative pressure pressure dressing. It's not a suction. It's
mm,
not sucking. It's not sucking anything out of the wound. It's using negative pressure to apply pressure, if that
mhm,
makes sense. In my mind, that clarification was everything because I have actually had wonderment in the past of like, how exactly what's the mechanism of action of this device? Like, what is going on? Why can you put it on open wounds and closed wounds? And these
mhm,
professionals, these clinical support professionals come in and just give us all the tea. They're
mhm,
available out they've got their oh, we haven't even mentioned the vendor forum that's out there. We've got different vendors
mhm,
at different tables, and so we have long breaks where we can go out there and network with the vendors. You can go to the tables and ask all the questions, and they are so, uh, very informative, and you've just got lots of time to get information on these things that you're using in real life, and we all know how it is. A lot of times you're thrown into cases and situations where you're using products that your hospital has, but you haven't had an official in-service from the professional that needs to be giving you the information
mhm,
on the product. And I can't tell you how much emphasis I place on the importance of that for me. I really like to know the manufacturing, the directions, the indications, contraindications, pitfalls, and pearls, and all those good things.
mhm.
So I don't have to even tell you how much I enjoyed this and got some really good notes from them.
Oh, it was this was an eye opener for me. I mean, I used to
Mhm.
Pico quite often, and I learned things that I did not know
Mm.
because sometimes you pick things up as you go along and you make your own assumptions about what they mean rather than and I've had a few in services on this, but never to the extent and the amount of in-depth they went into these. Like one huge takeaway for me was what way do you orient it? You have a pad and you have the cable that comes off that hooks up to the suction device. If you're putting it on a knee, do you put it dependent side down? Do you put it cephalad? Do you put it I mean, what way do you do it? And I always figured, oh well, gravity drains down, but
We treat it as a
they
drain,
stressed
right? Mhm.
right, but they said that's not correct because
Mm-mm.
this is a canisterless system. So part of the canister is in the dressing in and of itself. And number one relies on transpiration to evacuate off some of the fluid. So you never want to cover it with an occlusive dressing like an Ioban or anything. But if you put it with the suction cable down in the dependent position, it could read as prematurely full when it's not. So that to me was an eye opener. And the more this is why it's so valuable, especially for us, because the more I know about something and I know the correct indications and what it's for, I can suggest it at the right time to the surgeon for the right hey, this is a patient that needs a pico for this reason, that reason. This is the second dressing we've done. I think we should put a wound vac on it because I think it'll help. Collapses out the dead space. And just hearing that, what you mentioned earlier about it's a pressureless pressure dressing is in a sense of what it is, made complete sense for C-sections. I mean, I work with surgeons that always put it on a C-section, but so maybe if I have a juicy wound, I can put it on because I need that little extra amount of
Yeah.
protection. I need that extra pressure on there because let's face it, doing an actual pressure dressing with elastoplast tape like it's supposed to be done causes a lot of issues with their skin, a lot of blisters, and then,
And can be a
one
ni
thing
that
they
then in turn, let's think like a surgical assistant should think is that in turn is a nidus for a wound infection. I mean, if you're tearing that
right, that
skin up
creates other
and
issues,
that I
yep,
mean, you're creating a complete and there's if there's even a little pannus, but even if there's not, you're creating a perfect environment, a perfect storm, if you will, for a surgical site infection to happen. So you're right.
mhm,
We don't want to be stretching anything over. I mean, yeah, just the takeaways from this, we could have talked a whole episode on this one thing, you know.
right, and
Um,
hospitals can always get behind that because they're always looking for ways to decrease SSIs, and this is
mhm.
a great way to decrease your SSI, and
Right
this
there,
is
John. Weren't there people in the room that had that same misconception? I never
mhm,
really thought about it. Again, I guess I haven't used it as much as some people have to where I even thought about even having that misconception, but how so many people in the
mhm,
room thought the exact same thing. They thought they were thinking of it as like a drain and positioning that canister in a downward or to the side,
mhm,
motion, which I guess if it's lateral to the side, it's not gonna make that much, but if it's especially if it's a vertical incision, they would put it at the distal part of they would put the canister at the distal, and you could see light bulbs go on in everybody's head. I mean,
mhm, oh,
everybody was
yeah,
like, "Ding, ding, ding," like, "Oh my god, we did not know this," and all it does, and the primary reason, of course, is it gives it a false it'll make it alarm and think it's full when it's
mhm,
not full. So many so many good takeaways, and
yeah.
we just can't talk enough about it, y'all. I mean, it's just
Well,
we
for me,
want to give you all the nuggets that we learn, but you just need to go. You just need to go to these conferences and
mhm,
get it for yourself. We're trying to give you a little bit, but
mm,
yeah.
and the
And I
next
love
was
how they
on,
talked about just they gave us wound care tips and tricks and just
mhm,
general wound care tips and tricks too, so do, 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 do.
Apsix Mesh was after that, she was another great
Yeah.
presenter,
Yes, excellent. So just learning about the phasics mesh and hernias go hand in hand with learning about mesh, of course, because that's what we're using them on.
mhm, but the benefits of synthetic over
This was
exactly,
so yeah, we know there's synthetic mesh. She talked to us about the different kind. There's synthetic mesh, there's biologic mesh, and there's bioabsorbable. And Phasix is a bioabsorbable.
mhm,
And she went into the science of it and how they created it and all these things. And so they gave us a really good tip at the end of this one. The website that you can go to. We're going to give you this information right now.
mhm. Taylor Twardowski was her name. I thought she was a really good presenter. She knew her information inside and out, and she went to the University of Texas at Austin, hook 'em horns. So,
Mhm.
it's funny she did
Yeah.
that even though her whole
Yeah.
family was Texas Aggies. But, yeah, the indications for bioabsorbable and synthetic mesh, and she talked a lot about component separation and the Reeve-Stopa procedure because that's where we use a lot of Phasix mesh, but just the benefits of Phasix mesh and how it dissolves versus it's a bioabsorbable mesh. In about 18 months, it completely absorbs. It degrades by hydrolysis, not an enzymatic decay. So it actually leaves behind a much stronger abdominal wall than it would if you'd use
Mhm.
some other type of mesh. But yeah, the resource I walked away with was their Hernia University or Hernia U. It's B&D Surgical Education. So it's herniau.com. You go there and create an account, and it's a wonderful resource.
Mhm.
So I thought that was
Yep.
great. And she left her contact information too. If you That's another thing about these presenters. I mean, they're open with their contact information and they're open and willing for you if you're
Mhm.
really stuck and you need their advice to reach out to them, which I think is
Mhm.
fantastic. So Yeah,
They're
that was another
enthusiastic
great
about their
lecture.
products, and they're the expert. I mean, they're completely knowledgeable, and also we can feed into them too, John. I mean, I've had times where I've brought up clinical, situations, practical situations that they're like, "Oh, we've never heard that before." So,
Mhm.
we in turn it's a symbiotic thing, we get a lot from them, but we can also give them great feedback
Oh,
too and bring some
exactly.
things to their mind, regarding their products. So just again, yeah, really great to hear from her. And yeah, that herniau.com, fantastic. I love walking away with good
Mhm.
resources that we can have and use. So we wanted to pass that along to you, the listener. Next, we heard from Luis Aragon, who is the former president of
Mhm.
NSAA, and he talked to us about ethical changes in the surgical area, surgical decision making, and patient advocacy, navigating moral dilemmas in the OR. And John and I were particularly our ears perked up on this. I mean, on this, I'm sorry, this lecture because we are in the process of putting together. It's probably going to be the next one that we record is going to be a episode on ethics in the operating room and all the different
Mhm.
things and challenges that we could be faced with in our daily on the daily. I mean, we come
Mhm.
against things where ethics and morals play a big part in our position and in our career and what we do. And so he gave a great talk, Louis did. He's a great speaker. He's very
Mm. Yeah.
knowledgeable as usual. We talked about personal character and how our personal character
Mhm.
impacts our ethical choices. Sometimes you have to be able to separate that, though. Sometimes we have to be able to separate our personal beliefs, and I don't wanna get too far in the weeds in that. We're gonna really delve into that, so that's just a little hint for you to be listening up for that next episode. We're gonna talk about ethics in the operating room. But he went on to talk about informed consent, um, and gave us some scenarios of when patient, you know, just, I guess, current standards and situations regarding patient consent. And as part of the team in the operating room, John, we always, always, always have a obligation to stand up for the patient and speak up for the patient when we have any questions in an appropriate, obviously, an appropriate and professional manner. What did you take away from his talk?
Oh, there was a tremendous amount I took away from his talk. I agree with you. He is an excellent speaker. He's an excellent writer. He's that type of writer and speaker that I'd like to be. I mean, he's very it's very well thought out. It's very well researched. It's very well presented. But this is especially timely for all of us. I mean, we need to keep this in the forefront of our mind. He talked about coerced consent and informed consent, and then how should the surgical team advocate for their patients. But what is the ethical responsibility of the surgical assistant? He talked about ethical boundaries, the duty to speak up for patient safety, like you mentioned, ethical limits of the surgical assistant. An example he gave was a senior surgeon pressures a surgical assistant to perform a procedure beyond their training. What do you do in that situation?
Mhm.
And if you always keep these ethical precepts in mind, you will protect yourself and protect your patient. You won't be put in a situation where you can be sued. That's what I love about these lectures. These things are so relevant to us. And he brought up an incredible point that we all know, but not a lot of people talk about is social media. What are the ethical concerns with that? Do you get consent for the patient in their informed consent that there might be a possibility of pictures being taken or students being in the room, or but is it on the OR posting and is it on the surgical consent? And then he brought up the ethical fact of medical tourism. Where does that leave us when a patient goes to, like, I've had this happen to me, patient goes to Mexico for a breast augmentation, comes back and shows up in the ER at 2 in the morning completely infected and on the verge of septic shock. They can't just jump on a plane and go back to Mexico and have that surgeon fix it. Now a surgeon in the community takes on that responsibility and all of the liability. That surgeon in Mexico isn't going to face any of that stuff. So it's a huge concern now because so many people are going to different countries for different types of procedures, whether it's hair transplants or bariatric surgery or cosmetic surgery. Brazil used to be and it probably still is a place that people go for inexpensive but quality plastic surgery. But now Mexico is taking that over, Thailand is taking that over. So, and then ways of strengthening ethics in the OR. So, I thought it was an excellent,
Yeah.
excellent lecture,
Yeah.
and he's got a lot of articles posted on his LinkedIn account
Mhm.
on the National Surgical Assistant Association has links to that, and his own personal LinkedIn page has his
Right.
articles listed. So,
things he said is team trust is integral, and I can't say enough about that. That it's so important, and we're gonna
Mhm.
talk more about that in our episode on ethics. So, it was very timely discussion for us because we had already been,
Yep.
started our conversations about, recording an episode on ethics in the operating room. Um, I'm gonna
Mhm.
let you talk a little bit about legislation. I know we're running out of time.
Okay.
We don't wanna get too far in the weeds, but just to kinda let hit the
Yep.
high spots, the high points of what they talked about in legislation. It's always great to hear what they're doing behind the scenes. There's
Exactly.
something that our organizations guys are always working on, getting that legislation passed in states to require us to be licensed is what we're talking about. I mean, that's the crux of it, isn't it, John? That we're working
Yep.
towards getting a requirement for us to be licensed, for that to be in legislation, brings validation
Mhm.
to our profession, and it holds us to a higher standard, and it allows for us to be recognized by insurance companies and whatnot as far as billing and reimbursements, and it just affects us in a whole lot of ways. And it's just literally like chipping away at an iceberg. It takes time, it takes money, it takes time. So
Mhm.
I've learned a lot, and I don't know the half of it, I'm sure, but I've learned a lot since coming into these organizations on what it takes to pass legislation in states. So John's going to talk to us about what they told us at the conference on this front.
Yeah, this is just a brief overview of things like a situation report, basically.
Mhm.
But, one thing Kelly and I have talked about is having a podcast just dedicated to legislation and how and what it entails and who it entails. And basically, it's a grassroots effort. If you want licensure in your state, it has to begin with you. A lobbyist, they will send a lobbyist when it gets to a certain point in the process, but they can't do it before that. So, but we'll get into that in depth in that episode. But basically, just a brief update on what's going on. Rhode Island, its bill made it to the governor's desk for licensure in Rhode Island for surgical assistants, but it was vetoed. He vetoed it. So there's a new bill making its way through both houses, and we'll have more on that in the future. Massachusetts, they had issues with surgical assistants and nurses in the past. So now there are two bills in House committee, and that's moving forward. So I know this is just basic overview. I'm not getting very in depth because there's a lot. We can go way down in the weeds in this, but for all you need to know is Rhode Island's bill made it to the governor's desk. He vetoed it. Now there's a new one moving through the House committees. Massachusetts, there's two bills in the House committee and it's moving forward. Ohio, there's a bill for licensure moving through committee and has the possibility of passing this year, which I think is great. And thank you to everybody in Ohio who's pushing that forward. And the more those states around them get licensure, if Ohio gets it, then Michigan might be next. Indiana, all the states that border it are going to be primed for that. So, and let's see the possible future licensure and legislative efforts looking at Georgia and Florida. So, also one thing that they talked about was a letter that was written that you can send to your state legislators. And I got a copy of that from Jeffrey McNeve, the treasurer for the Association of Surgical Assistants, and I will pass that along. I can link it in the show notes, I think, or if not, I can attach it in the show notes. So that's something that people can take and use, but it's on the website, and or you can email the ASA or NSAA and get a copy of that letter. So that's basically where we stand as far as the updates in legislation, and always more to be revealed in that. And then after that, they talked about question and answer time at the end of the conference. It wrapped up a little bit early so they could dedicate more time to answering questions about the new American Academy of Surgical Assistants. However, there's still not a lot of information to be had. So just basically my highlights I took away from that: two pathways to eventually one organization, one certification in the future, but change takes time. Just getting started, still more work to do. Does not affect certifications as they are right now. There still will be a CSA from NCCSA and the CSFA from the NBSTSA.
Mhm.
I think that's all I wrote. So I don't want to show you my diagram because it's not for all audiences because I wasn't paying attention when I was drawing my diagram, and
Right.
it can be viewed in a rude way. So I won't do that. But
But, yeah, that's it. That's it. We're, excited
great
we got to
conference.
go. We're looking forward to next year. Next year, they did announce that it's going to be in Atlanta, Georgia, the weekend after Easter
Right.
2026. So I did write that
Excellent.
down so we could, forward to that. Um,
Hmm.
so it'll be another joint conference in Atlanta, Georgia, 2026, and I wrote down that
Hmm.
they said the weekend after Easter. So if you wanna mark that on your calendar, go
Wonderful.
ahead and just kind of tuck that away in the back of your mind. well worth it, guys. I've never regretted money. He said, "Does your organization send you here?" Because some people work in hospitals and organizations that
Mhm.
will send them and foot the bill and send them, and that's fantastic. I have never been that privileged. But, I have never regretted, I've never regretted spending the money on myself, John, and investing in my
Oh,
profession and in
exactly.
myself this way. So, a little bit of a sacrifice, but you get those CEUs that are much needed, the advanced and live CEUs that are needed, and, great networking. I met a great group of
Mm,
girls from Minnesota,
mhm,
Mayo Clinic, learned so much from them and about their program. 2 of them, it was a group of 5, 2 of them were instructors in their, surgical assisting program, just fantastic girls. I hit it off with them immediately, and it's just so enriching. I can't tell you enough about how enriching it is to go to these conferences. So,
mhm.
just want to end this episode just encouraging you again. John and I are on the same page with this, just encouraging you to get involved, get involved, get involved. And we want to keep you up to date on what's going on and our part as well with that.
Yes, and the other thing I'd like to say too is these are professional expenses, so I would definitely check with an accountant, but as far as I know, they are tax deductible. And I do know that most hospitals will reimburse you for conferences if it's related to your profession. I know when I was a surgical tech, I went to the AST meeting in DC and my hospital reimbursed me for most of it. Not all of it. They usually have a cap, and usually with the airfare and hotel and all that, you exceed that, but and unfortunately, I wasn't able to make it to the Maddox conference this year. I had some changes and I just couldn't make it, but I will be going next year, inshallah. And then I will do the ASA conference, my week of conferences, and that usually satisfies all of my CEU requirements. Last
You're
year, between the two conferences, I got a total of 59.5 CEUs. So more than enough I had to re register this month or recertify this month. So I just recertified with my CEUs for the CSFA exam. I'm good next year on my CSA, but definitely avail yourself of a conference. You're doing yourself a disservice if you don't make at
Yep.
least one, and I guarantee if you make one, you're gonna wanna make more,
Mhm.
I think it's fantastic. If you consider yourself a professional, you need to do it for professional development.
Yep.
So,
Yep. So,
but
yeah,
keep in mind.
great. Great
Mhm.
information. We thank you for joining us, everybody. Again,
Yes, thank you.
subscribe, keep those comments coming.
Mhm,
We try to answer. I love getting comments and questions from you guys
mhm.
and feedback. Michael Morrison, shout out to Michael Morrison, was sure to tell us that we're a little bit long on our episodes.
Yeah, so we
That's
purposely made
fine.
this one an hour and
That's
8 minutes,
right,
Michael.
Michael. And then John and I both were like, "Well, I prefer long podcasts because if I'm on a long drive, that means I can like." But joking
Yeah.
aside, I appreciate it. We appreciate the feedback, and we've had to hone it down, but there always seems to be so much to talk about. But
Mhm.
it is what it is, and we are being intentional about not
Yes.
repeating and going over the same things and keeping time the forefront of our mind. But we can't help it if there's a lot to talk about, guys. Just fast forward through some
Exactly.
of the parts you don't like.
But you tell us. I mean, if you think, "Oh god,
Mhm.
it's long-winded," I don't granted, you can
Right.
pick it up and start over, pick up where you
We
left
need
off, but
critique,
you tell us.
we
Yes, and we
yeah,
would really appreciate like, commenting, and subscribing because that helps the YouTube and the other Spotify and other algorithms pick that up and push it out to more people,
absolutely.
and definitely, if you could leave us a review on Apple Podcasts, on wherever you listen to your podcast, if you could leave us a review, that would help us tremendously get it out to more people. I
Yeah.
mean, this thing isn't monetized, and honestly, I don't think we'll ever monetize it because I hate listening to podcasts and having to listen to an commercial.
I know, to you. So,
No, because
purely
this is
informational and professional,
yes.
and we appreciate that we're able to do this. So, yeah, we
Mhm.
hope we're helping
But
you.
yep, ask any questions, you've got things you wanna hear about, learn about, know about, just reach out to us, and we'll do our
Mhm.
best to get it handled and get you the information. So, keep an eye out for that ethics podcast that'll be coming out, and then probably right after this one, and then there'll be one eventually on legislation. I think we need to do that because I think a lot of
Mhm.
people have questions, and I think we can maybe get one of the legislators on to talk about that would be a great resource. I'll have to reach out
Mhm.
to my contacts at the ASA or NSAA and get that information. So,
Yep.
thank you for joining us once
Okay.
again.
Yep. Thank you. Bye, everybody.
Take care. Thank you for joining us today. We invite you to like, comment, and subscribe to our podcast. Feel free to look us up on Facebook at the Surgical Assistant Podcast. If you like, you can also email us at thesurgicalassistantpodcast@gmail.com. We look forward to seeing you on the next episode. Content of this podcast is created for surgical assistance and is educational only. It is not intended to diagnose, treat, or offer medical advice on surgical conditions. No patient-specific information is shared, and all HIPAA guidelines will be adhered to.